بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. أعزائي أبنائي الطلبة، يتجدد بنا اللقاء مرة أخرى في محاضرة جديدة من سلسلة محاضرات Ophthalmology Made Easy. وموضوع اليوم سيكون عن استخدامات الأمنيوتيك membrane in ophthalmology. As I used to say that these lectures are targeting postgraduate students who are willing to appear in the FRCS or the Libyan board exam. Our lecture for today has a special title, not only for your exam sake or for the scientific purpose, but also it gives you the impression of the profound capability of our creator that make this thin, fragile membrane, that's the amniotic membrane, capable of providing the vision and the life for people who are outside the intrauterine life. Amniotic membrane is not just a thin, humble membrane that protects the baby and nourishes the baby, but also it has the power of the principles of regenerative therapy that we will speak about it later on. So I ask you to follow carefully this lecture and write down every and each important notes, not only for the sake of your exam, but also to realize the capability of our creator and the wisdom of our creator that makes the regeneration in our body itself. So let's dive deeply and go and see what's inside. Thank you very much. Now, as we use it to start with the intended learning outcomes, in this lecture we will start with a brief introduction to the amniotic membrane, but concentrating on speaking about the different parts of the FRCS and the reason why I choose this subject, as it is an important subject, especially in the FRCS exams for postgraduate students. So we will speak about the importance of this subject in different parts of the FRCS and among the different syllabus of the FRCS. We'll speak about the meaning of amniotic membrane, biological properties and indications of use in ophthalmology, also how to prepare and preserve the amniotic membrane, and then we will speak about the different surgical techniques and clinical applications and the outcomes and complications and future direction and the latest advance in the amniotic membrane therapy, and finally the reference. So I would like you to enjoy this lecture, concentrate carefully, and this is very hot topic that each candidate in the postgraduate section should be aware of this subject. Now, when we speak about the amniotic membrane, we shouldn't forget to mention a few words about Professor Herminder Dua, who is the chairman of the ophthalmology department in the University of Nottingham in the United Kingdom. And he's one of the most contributor in the field of amniotic membrane. And he was one of the people who revolutionized this type of surgeries and techniques and the different applications of these techniques in the ophthalmology. As you know that among the achievements of Professor Herminder Dua is that he discovered the Dua's layer as a distinct layer in the cornea, so that the cornea is made up of 6 layers instead of the traditional teaching that is made up of 4 layers. He's pioneer in the amniotic membrane transplantation and ophthalmology, and he played a role in the definition of or the applications of amniotic membrane in the ocular surface problems, and also has a profound work in the limbal stem cell deficiency treatment and ocular surface reconstruction. Currently, he is the president of the Eurocornea, the European Association for Vision and Eye Research, and one of his famous statement that healing the surface of the eye is about restoring comfort, vision, and quality of life. And amniotic membrane is a beautiful example for how we can harness nature's own healing power to help the eye recover in the gentlest possible way. This is one of his famous statements regarding the role of amniotic membrane in the healing process on the ocular surface problems. Now, before I start speaking about the subject for today, which is the amniotic membrane and its application on ophthalmology, I like it to start with this slide, speaking a few words about the parts of the FRCS exam and the syllabus. And the reason for that, I would like you to realize the importance of the subject for today in this exam. As you know, the first part is meant mainly for assessing your knowledge in the basic science and is mainly made up of MCQs, around 160 MCQ, a single best answer question with no negative marks for 2 hours. And these are the different syllabus that you are engaged or asked to be aware of them in the first part exam. And this is a sample of the MCQs for the first part exam. You can see that is 5 structured questions with a single best answer. Now the second part is 2.5 hours exam, which is made up of 180 single best answer questions, MCQs, and the syllabus are the clinical part of ophthalmology. Now the subject for today will be in this area, that's the conjunctiva and corneal problems, because it covers the ocular surface problems as well as the corneal pathology. But also our subject for today is important also for the third part exam, because you are going to face both clinical and oral examination. The oral exam will be made up of 3 stations for 20 minutes, one for lid and oculoplasty and anterior segment, and this is the lecture for today will be in this area. And the posterior segment and the glaucoma, this is another station, and then the neuro-ophthalmology, motility, and general medicine. Then you are going to go to the clinical part, which is made up of 4 stations. You will stay for 12 minutes in each station, and you are asked to assist the anterior segment, posterior segment, neuro-ophthalmology and motility cases, and oculoplasty and lid disorders. And in this area also you will face the amniotic membrane applications. You might face a case in this session. So in general, our subject for today is very important for the FRCS exam. It is a new subject and growing very fast and very rapidly, and promising very good success and the management of these chronic diseases of the eye. So you should be aware of it. Now the example, this is example of the OSCE exam in one of the stations. For example, you are confronted with a case of amniotic membrane, either in the laptop or as a picture, and the examiner will ask you to explain to your patients what's the meaning of amniotic membrane transplant. So you should be able to answer and to describe the indication and the mechanism of action and outline the steps of the procedure of the surgery of amniotic membrane transplantations. And also he might simulate for you a scenario, a case scenario. For example, 45 years old male with 4 weeks history of alkali injury, complaining of pain and blurring of vision. He asks you on slit lamp, no healing epithelial defect, no active infections, and he will ask you about the management as far as the acute management as well as the chronic management. So at the end, I would like you to realize the importance of our subject, important, especially in the second part and the third part exam. And this is the marking sheet. This is the marking sheet of the when you are asked to examine a case in the exam. So the examiner will total marks. You will have 22 marks. There will be some marks for the patient communication, how you explain to the patient in his simple language. Also, when you answer, for example, the indications for the persistent, for the use of amniotic membrane, for example, persistent epithelial defect and chemical injuries and so on, you will have a mark out of 3. Also the mechanism of action, also the technical knowledge, procedure, risk, complication, post-operative case care, and the confidence, and also they will assess your confidence in answering and either speaking to your patient or answering your examiner. So this is how the way they distribute the marks in the OSCE case. So out of 22 you will be given how much marks you get from this station. Introduction of the amniotic membrane, a brief historical prospect about the initial attempt of use of the amniotic membrane through this a very long journey of amniotic membrane applications on ophthalmology, which has been evolved, dated back to 1910, in which first application was mainly as a skin graft and skin burns. And after that, at the 1940s, the first one, that's D. Roth, who first documented the benefits of using of the amniotic membrane in conjunctival reconstructions. After that, a long period of the disappointment has been happened because of the failure for the preservations of the amniotic membrane till the beginning of 1995, in which the T-Song, who revolutionized the amniotic membrane applications on ophthalmology, especially in recurrent corneal erosions and different applications, because at that time, at the early 20,000, the development of the recent preservation techniques like cryopreservation and lyophilization, so that this revolutionized the use of amniotic membrane in ophthalmology. And now, by the beginning of the 2000, huge applications of the amniotic membrane and the expansion of its applications to involve the glaucoma surgery, vitreoretinal surgery, also intraocular use. So till now, reaching up to the femtosecond assisted pockets inside the cornea to assist in implantation of amniotic membrane. So this long journey from the forgotten tissue that is not important and neglected by doctors to become a cornerstone in the ocular surface reconstruction and also in the intraocular regenerative therapy. This is a scientific achievement that this membrane carries a hidden power for regenerative therapy. What's the amniotic membrane? The amniotic membrane, as you know, is the innermost components of the placenta that's facing the baby. The outer part is known as the chorion, and the inner part is the amnion. This amnion forms the most inner part facing the baby, that's protecting the baby, and contains most of the important biological growth factors that support the baby. That's why in ophthalmology we are more interested in this layer. And this amniotic membrane is very thin layer, 0.2 to 0.5 millimeter, and it has made up of 5 layers: the epithelium and the basement membrane from one side, and the stroma, which is made up of the compact layer, fibroblast layer, and the spongy layer. And it contains different types of collagen fibers and fibronectin and laminin and other growth factors. However, histologically, the most important is the basement membrane that provides structural support, as well as the compact layer, which is full of the essential growth factors that is used for the healing process, promotion of healing, prevention of fibrosis, and in the reconstruction of the ocular surface. So this is the amniotic membrane, as you can see here, and it is mainly made up of the epithelium and the stroma. And the stroma, as I said, made up of 3 layers: the compact, fibroblast, and the spongy layer. Now, the importance of the spongy layer is a sticky layer. So once you hold the amniotic membrane in your hand, the layer which is stick to your hands is the spongy layer. This is very important to determine the direction and the orientation of the amniotic membrane. And we will speak later on the importance of using the epithelial basement membrane side or using the stromal side in different pathologies of the cornea and conjunctiva. So as I said, that it is made up of different collagen fibers, different growth factors. You can see that type 3 collagen is predominant in all of the layers. So this is in brief the meaning of amniotic membrane and the components of the amniotic membrane. Now, after we have spoken about the anatomy and the histology of the amniotic membrane, now let's see what are the biologically active components of this membrane that make it very important structure in the healing process and regeneration of the surface of the eye. The main components are proteins, namely the collagen. As you can see, different types of collagens are there. And laminin, fibronectin, elastin all contribute to the structural integrity of the membrane, also promote epithelial adhesion and migration proliferation, and they support the flexibility and elasticity of this membrane. Another important component is the growth factors. There are plenty of growth factors that plays a major role in the regulation of the healing process and the fibrosis, and also promotes the the cells motility and healing process, namely the epithelial or the epidermal growth factors, the transforming growth factors, the keratinocyte growth factor, hepatocyte growth factors, and basic fibroblast growth factors. Another important components are the anti-inflammatory and the cytokines, especially the interleukin-10, interleukin-1, and a lot of other mediators that control and regulate the inflammation as well as the fibrosis and protect against the proteases-induced tissue damage. And finally, a lot of antimicrobial and immune regulatory agents that regulate the immune response of the host, as well as they have antibacterial and antimicrobial functions, namely the beta-lysins and lactoferrins that prevent the growth of the microorganisms. So from this anatomy and this physiology, you can understand that amniotic membrane is not just merely a very thin membrane that warps the baby during the intrauterine life, that's nourish the baby and protect the baby, but also it has extended role beyond the delivery of the baby that's make the doctor interested in this membrane, as it is showing the profound capability of our God and the Creator for this membrane that plays a major role in the control of inflammation, proliferation, and regeneration of the tissue. So although this is very small, very thin membrane, but yet has a profound and strong role in the control of the ocular inflammation, and namely the ocular surface problems. Now, after knowing the anatomy and the main biologically active substances present in the amniotic membrane, we can classify the role of an amniotic membrane as follow. It has an anti-inflammatory function that's important in chemical injuries and autoimmune diseases. Also, it has an anti-fibrotic role that prevent the fibrosis, especially after the doing operations like pterygium surgery or even glaucoma surgery or conjunctival reconstructions or following any malignancy of the conjunctiva. Also, it has an anti-angiogenic role that's prevent the unwanted blood vessels, and this is, as we have explained in the lecture of the limbal stem cell deficiency, this is very important in the growth of the limbal stem cells. And it has also antimicrobial activity that help in the healing of the unhealed corneal ulcers or neurotrophic ulcers or any pathogens present in the corneal surface. Also, it promotes the epithelial healing by encouraging the proliferation, regeneration of the epithelial cells. And this is, of course, would be very useful in the persistent epithelial defects and recurrent corneal erosions and neurotrophic corneal ulcers. And as far as immunology, it has very low immunological risk for rejection because of the good immunological prevalence. And this make it very safe and very suitable for allogenic transplantation without the risk of immune suppression or the need for immune suppressions. And as you can see that the dual function of the amniotic membrane as a biological bandage, so we can utilize its anatomy as a biological bandage and the substrate present in the stroma to promote the cellular growth and proliferation of the cells, make it very suitable for ocular surface reconstruction. So it has two dual roles as anatomic, as biological barrier, as a bandage contact lens, as well as the substrates present in the membrane that help to promote the proliferation of the ocular surface and prevent the fibrosis and the inflammation. So it is very suitable in ocular surface problem. So in summary, the main goals of the amniotic membrane, it acts as anti-inflammatory and anti-fibrosis and promote epithelializations and very useful in ocular surface problems. And it is useful in the sympathetic or symptomatic relief of the pain of the eye. So this is the main goals of the use of the amniotic membrane in ocular problems. Now, by studying the phenomena of the amniotic membrane and its applications and the vast application of this membrane in different types of the diseases, that it is sometimes you feel that there is contradictory between the rules. For example, when it acts as anti-inflammatory as well as promote healing and also anti-fibrotic. So this phenomena of the amniotic membrane elicit a new concept which is known as the passive therapy versus the active therapy. What's the meaning of passive therapy as compared to the active therapy? Now, when we speak about the contact lens or the steroids, both of them are classified as passive therapy because it is a single action therapy that reduces the inflammation but may delay the healing. And this is expected when you eliminate or reduce the inflammation. This will end up by delaying the healing. And instead of healing within a few days, the healing will complete it in weeks. And this is named as a single action therapy or passive therapy. This is applicable for contact lenses and steroids. However, the active therapy or the dual action therapy, which controls both the inflammation and at the same time promote scarless healing. So it controls by damping the inflammation, but this not in the expense of the healing. And this also will lead to decrease the scar formation. And the amniotic membrane is the best example for this active therapy. That's why it is named as a biological corneal bandage contact lens. So this concept is very important, that when we use the passive therapy like contact lens or steroids, this will be on the expense of the delaying the healing process. However, when you use an active therapy like the amniotic membrane, you will achieve the goals that what you need, but this is not in the expense of the healing process. Now, the secrets of the amniotic membrane that makes it responsible for the what's known as active therapy, as explained before, that it promotes healing with minimum scar formation. This is because of its modulation and control over a physiological pathway, which is known as the epithelial mesenchymal transition, and the reverse of this pathway. Now, to understand this, I will explain how the amniotic membrane can promote healing but without scar formation. Now, the next discussion will be regarding this epithelial mesenchymal transition and the reverse pathway, which is the mesenchymal epithelial transition. As I said, that the secrets of the amniotic membrane that it supervise the active therapy process that is promotes healing and prevent the fibrosis is through the augmentation of this physiological pathway, that's the epithelial mesenchymal transition. By this pathway, the epithelial cells of the amniotic membrane will acquire some of the features of the mesenchymal cells, that they became motile and capable for invasion and formation of the extracellular matrix and resistance for apoptosis till the healing process takes place. Then it will revert back by the reverse pathway, that's the mesenchymal epithelial transition. Now, when you look to this diagram, this is the diagram for the normal epithelial cells, in which there is hemidesmosomes between the cells and the basal lamina, and there is tight junction also between cells. And also the cells, they have a what's known as a polarity, that they have an apical surface and a basal surface. Now, upon stimulation of the healing process made by certain mediators of this pathway, now the cells will start losing the tight junctions and the hemidesmosomes and lose the contact with the basal lamina, and the cells will acquire a special shape and lose of their polarity. So there will be no more difference between the apical and the basal surface, and by this way the cells are capable from detaching from the basal lamina, and then they acquire the invasion process and becomes capable for motility. Now, this process is done by the help of certain mediators that promotes this pathway. That's the conversion from mesenchymal cells to epithelial cells. And also there is another mediators that promotes the reverse, that's the conversion of epithelial cells to mesenchymal cells. Now, the amniotic membrane is capable for regulating this pathway. Once the healing process is needed, it will carry the direction in this pathway, that's toward the formation of mesenchymal cells. When the healing process finished, it will carry the direction of this pathway into the reverse. By this way, there will be no excessive fibrosis. This is the mechanism how the amniotic membrane responsible for the active therapy, that is promotion of healing without fibrosis or with minimum fibrosis. Of course, this process is taken with the help of a lot of mediators that control this pathway. Now there is an important dilemma that should be explained, and also this is very important because many doctors ask in this point. Do you feel, or from our previous discussion, that there is an apparent contradiction between the role of amniotic membrane as promotion of healing, at the same time it is an anti-scarring role? As you know, when we say that it promotes healing, it means that it promotes the inflammation so that it will end up by healing, because one important integral part of the healing process is the inflammation. And at the same time, it has an anti-scarring rule. So how can we understand its role as a promotion of healing as well as it is an anti-scarring? This is what I mean. Apparently, you will feel that there is a contradiction, but this is not the case, because the amniotic membrane, as you know, for any inflammatory process, as you know, there will be some mediators that promotes the inflammations, and this inflammation will end up by healing. And if this inflammatory process continue and the mediators don't disappear, this will lead to activation of the plenty of fibroblast, and this fibroblast will be converted to myofibroblast, and this is the problem. That's the myofibroblast will end up with extensive fibrosis and contraction of the tissue, and we will face the unwanted effect of the fibrosis. So the role of amniotic membrane, it acts as a balance between the inflammation promotion as well as the inhibition of the fibrosis. What we want unfibrosed scar. That's, we want healing without fibrosis, and this is done by various factors. That's done by the amniotic membrane, that it has mediators that promotes the healing process and promotes the inflammation. But at the same time, when the healing process takes place, immediately it releases another mediators that prevent the conversion of fibroblast to a myofibroblast, and so it to prevent the fibrosis. And this is very useful in the presence of cicatricial ocular surface problem, like ocular cicatricial pemphigoids or Stevens-Johnson syndrome, in which we don't want fibrosis. So it has a major role in this regard. So this is named as context dependent. The role of amniotic membrane is a context dependent. What does it mean? It means that it acts as depends on the case. It depends on the environment that's present in the eye. If there is defective epithelial healing, it will promote healing. If there is excessive healing and there is excessive inflammation and tendency toward fibrosis, it will dampen and prevent the fibrosis by release certain mediators like the inhibitors of the transforming growth factor beta 1 and beta 2, and prevent the fibrosis. This is known as context dependent rule. So apparently there is no any contradiction between its role as promotion of healing at the same time as anti-scarring. So the home message that the amniotic membrane plays a physiological role, that's it supports physiological healing while suppressing pathological fibrosis. So it is useful in acute problems and in chronic problems by playing or maintaining the balance between these two forces. This is what's meant by the dichotomy of the amniotic membrane, that has dual role in the promotion of healing as well as prevention of fibrosis. So by understanding the context-dependent role of the amniotic membrane, so we can understand its role in the management of acute ocular problems. Acute means like in chemical burns, so or thermal burns. We can immediately use the amniotic membrane on the surface of the patients, so that this will reduce the inflammation, but at the same time it will accelerate the healing and prevent the scarring. Also in Stevens-Johnson syndrome, because of the release of certain mediators, it is very useful to eliminate excessive inflammations and help in the healing and prevention of fibrosis. At the same time, it is useful in chronic diseases in which the fibrotic pathways and the conversion of the myofibroblast is very active. So it helps in prevention of the fibrosis, like in chronic ocular problems, and also useful in limbal stem cell deficiency, so that it prepare the environment for the proliferation of the limbal stem cells, and also in chronic Stevens-Johnson syndrome or graft versus host rejection, in bullous keratopathy and neurotrophic keratitis. All these chronic problems is characterized by a very active fibrotic pathway in which the fibroblast will be converted to myofibroblast. Now, the dichotomous role of the amniotic membrane plays a role in damping the fibrotic pathway in these cases. Now, in view of our understanding of the components of the amniotic membrane and the structure of the amniotic membrane, we will speak about some of the applications of the amniotic membrane in the field of ophthalmology. As we have mentioned before, there are a large number of applications of the amniotic membrane as far as the corneal epithelial healing, as well as limbal stem cell deficiency, corneal surface reconstructions and chemical injuries and conjunctival reconstructions, and also in different operations. The most common applications in the presence of persistent epithelial defects, as you can see here. And we explain that this is because of its role in promotion of the epithelial adhesion, migration, proliferations, and this will help in the healing of the surface corneal epithelium. And also it has a role in the presence of intractable corneal ulcers. Also it has a role in the corneal perforations. We will speak about this later. So in the presence of intractable corneal ulcers, one of the options is to use the amniotic membrane, owing to its antibacterial role as well as a promotion of healing of the epithelium. Also, its role in the limbal stem cell deficiency, as I have mentioned in the lecture of limbal stem cell deficiency, as it is used as ex vivo expansion for the promotion of the growth of the limbal stem cells. And then when we do slit procedure, we add the amniotic membrane to try to simulate the microenvironment of the limbal stem cells. Also, it has a role, of course, in the presence of chemical burns, either in the acute burn as well as in the chronic burns. We'll speak later on its role in the acute and the chronic inflammations of the eye. And also in the pterygium surgery, one of the options, especially in pars clara technique, that we, instead of using the doing the pars clara technique or using the conjunctival autograft, we can use the amniotic membrane that promotes the healing and prevent the recurrence of the pterygium. And there are many studies shows that it has a very good effect in the prevention of the recurrence. Of course, conjunctival reconstruction, when there is shortage and fibrosis of the conjunctiva, one of the major alternative option is to use the amniotic membrane to cover the eye using the amniotic membrane. Its role in glaucoma operations, especially covering the trabeculectomy or the shunt tube or the stent of the shunt, also in the presence of defective conjunctiva, and to form the bleb by using the amniotic membrane. Also, as I said, that in the presence of valve surgery to cover the stent of the shunt or the valve operations. So as you can see, there are plenty of applications of the amniotic membrane. This is one of the applications in the presence of corneal ulcers. You can see how they use the inlay graft. We'll explain about it later on. And also in the presence of ocular surface problems with persistent epithelial defects. So it has a major role in the anterior surface problems of the cornea. Now we come to the clinical application of the amniotic membrane in corneal perforations. Of course, there are certain indications for the use of amniotic membrane in corneal perforation, especially used as a tectonic graft or support for the perforation, especially in the presence of small non-traumatic perforations due to corneal ulcer or perforations due to autoimmune diseases, or due to infectious keratitis, or sometimes corneal melting. So in these cases, provided the lesion is less than 2 to 3 millimeters, it can be treated with sutureless amniotic membrane only, as I said, as a supportive tectonic support to the eye till you will plan for another subsequent surgery like keratoplasty or any other surgery. Also in the presence of dysmatocele or impending perforations, so you can support the cornea and the stroma with the use of this amniotic membrane patch. And the same procedure is not suitable if you have large perforation more than 3 millimeter, or you have extensive tissue loss, or there is uncontrolled infections. In these cases, the amniotic membrane will not be helpful. Now you can see in this procedure that he injected the air first to separate the iris from the wound, then he applied this patch of the amniotic membrane so that it will promote epithelialization and support the cornea. And this is using the glue, so mainly amniotic membrane with fibrin glue. The most common available brand in the market is the Procera, which is very useful in these cases. So among the uses of or applications of amniotic membrane is in perforation, provided certain indications, especially the size. It should be less than 2 to 3 millimeter. It will be helpful in these cases. Now we come to the application of the amniotic membrane in the persistent epithelial defects. Persistent epithelial defect is defined as when the corneal wound or the conjunctival epithelial wound will persist for more than 2 weeks in spite of the standard medical treatment. And the reason for that, there are plenty of reasons. And the top of them is the presence of neurotrophic keratopathy, whatever the cause, due to diabetes or herpes or any cause. Also the presence of dry eye, limbal stem cell deficiency. This is the most common causes of persistent epithelial defects. Also post-infectious keratitis, trauma, chemical burns, and autoimmune diseases. Now here it is important to know how to apply the amniotic membrane. We have to apply it where the basement membrane epithelial side should be facing the cornea and the stroma should be up. So that the reason for that this orientation act as a scaffold for promotion of the epithelialization and help in the regeneration of the basement membrane of the corneal epithelium. And also there are plenty of mediators that prevent also the fibrosis and promote the adhesion of the regenerated epithelium. So this is very important, as you can see here in this video. After removing the denuded epithelium and the weak adherent epithelium, then the disc of the amniotic membrane should be applied, and as I said, we should pay attention to the orientation of the disc so that the basement membrane epithelial side should be facing down and the stroma should be up. Now this orientation, when this large band is in the right and this is in the up, this indicates that the epithelial side is down. So you just secure the patch corresponding to the area of the defect of the cornea, and then you apply it on the cornea and make it adherent strongly to the cornea. And after that, you can apply a bandage contact lens to secure the amniotic membrane is attached to the cornea. Now the question whether to use a cryopreserved or dehydrated amniotic membranes, this depends on many factors. One of them is depending into the underlying pathology. If you have a significant epithelial defect with serious underlying autoimmune diseases or the problems, you can preferably use the cryopreserved one, because the cryopreserved is more natural than the dehydrated one, plenty of anti-inflammatory factors, and it will promote rapid healing for the corneal epithelium. The disadvantage of the cryopreserved that it is expensive and sometimes not available at your hospital. The other choice is the dehydrated one is less expensive. Also, it has the advantages of promoting the corneal epithelium, but it is less bioactive as compared to the cryopreserved one. So it depends on the many factors whether to choose the dehydrated or the cryopreserved. Both are effective, but it depends on the availability and the underlying disease. But the main point that you should keep the face of the basement membrane and the epithelium should be facing down towards the epithelium to act as a scaffold for the epithelial migration. Now we come to another application or use of the amniotic membrane in what's known as conjunctivochalasis, which is commonly seen in elderly people and defined as a presence of redundant or loose and wrinkled bulbar conjunctiva between the globe and the lower lid. And this is usually missed as a chronic epiphora or watering of the eye. And actually it is due to a redundant conjunctiva, so that it is eliminating the space between the lower lid and the globe, so that there will be no space for the tear film to stay at that time. And usually the patient will present with tears and epiphora and chronic irritation of the eye. And this is due to this redundant conjunctiva, and it is commonly missed. As you can see here in this video, this is the space normally is filled with the tear film, which is between the globe and the lid. So this is the area of the bulbar conjunctiva. When this bulbar conjunctiva get hypertrophied and redundant, so this will reduce the space for the tear film to stay and lubricate this area. And this is the source of the complaints of the patients. As you can see, the patient will start complaining of epiphora and watering of the eye, and this area will be dry and foreign body sensation will be there. This is commonly seen in elderly people. As you can see, the eye is red, irritated, and watering the eye, and this is the redundant conjunctiva. So this is the conjunctivochalasis. Now, what's the role of amniotic membrane? Now, when we do surgical excision of this redundant conjunctiva, and then we apply the amniotic membrane, especially the cryopreserved one, that's the amniograft. So it can be used in more than one layer. So this will eliminate and reduce the inflammation, fibrosis, and the redundant conjunctiva will be eliminated, and the normal anatomy will be restored. So this is one of the applications. As you can see here, the disappearance of the conjunctivochalasis. This is one of the applications of amniotic membrane in this common OBD problems. Now we come to the applications of the amniotic membrane in strabismus, mainly restrictive myopathies, or any following any fibrosis to the conjunctiva that limits the movement of the eye, or due to adjacent or resurgery for strabismus that creates fibrosis in the naper area of the working muscle. So as you know, the amniotic membrane is made up of three layers: the epithelial layer, the stromal layer, and the basement membrane in between. Now, the stromal layer is the sticky layer which is attached to the nitrocellulose paper that we place the amniotic membrane on this side. So this side is very important because this one that we want to place it down facing the sclera and position to cover the defect required. So we should respect this orientation of the amniotic membrane. And another thing that we should use cryopreserved amniotic membrane, not the lyophilized amniotic membrane, because many studies shows that fibrosis and adhesion of the extraocular muscles have been reported with the use of lyophilized amniotic membrane. So in restrictive myopathies, it is preferred to use the cryopreserved amniotic membrane. And the mechanism of action, that it provides a barrier separating the fat adhesion from the attached sclera, and also as a tissue spacer to overcome or to cover the exposed sclera, and replacing the missing or contracted conjunctiva, and may reduce the scarring and prevent the recurrence. So the role of an amniotic membrane in restrictive myopathies is very important, because it is provide advantage of sparing or preserving the normal conjunctiva for other procedures like for glaucoma surgery or anything, and replacing the fibrotic conjunctiva by this membrane, and act as a barrier between the working muscles and the sclera. Among the advantages of the amniotic membrane in this regard, that patients' own conjunctiva suitability or availability is not a concern when you are dealing with a restrictive myopathies. So you are looking first for the suitability of the conjunctiva of the patient's own conjunctiva. Now, in this situation, it is not a big issue, because we are going to replace this conjunctiva with the amniotic membrane. Also, even the area that even a large graft available with amniotic membrane can be applied over a large area of the conjunctiva. So you don't need a large area of conjunctiva for grafting. So it is superior as compared to the conjunctival graft. And among the advantages, that it facilitates the healing with less inflammation and minimal scarring, so that it will help in the fast recovery after the surgery. So this is some of the pictures how we apply the amniotic membrane during the restrictive myopathy. So to sum up, preferably we use the cryopreserved amniotic membrane, and we respect the orientation so that the stromal area should face down the sclera, and we should apply it over a large area so that secure the elimination and reduction of the inflammation and the fibrosis. Now we come to another application of the amniotic membrane in vitreoretinal surgery, namely in the macular holes. Now, most of the retinal surgeons, they know that there are certain cases of macular holes, they carry a poor prognosis, namely those secondary to trauma or secondary to high myopia, and cases with persistent and recurrent macular holes, they carry a bad prognosis because of the loss of the functional photoreceptors in these cases. Now, many studies done using the amniotic membrane, they show a significant improvement in the anatomical as well as functional success, and this can be attributed to the role of the amniotic membrane as a biological plug that promotes the epithelialization and healing of the epithelium over the macular hole. Now, in this brief video presentation, I will show how the procedure of implanting this amniotic membrane inside the eye after the standard pars plana vitrectomy. This is a very small patch of the amniotic membrane is secured so that it optimized to be compatible with the size of the macular hole after being stained with trypan blue so that will be visible, and by special retina forceps you can see it is placed over the macular hole and the edges should be secured inside the edge of the macular hole so that it acts as inlay graft. So this is the procedure of using of amniotic membrane in retinal surgery. Now we come to another application for the amniotic membrane in the retinal diseases, namely in the optic disc pit. And all of you know that the optic disc pit is a rare congenital problem that usually associated with serous detachment of the macula. And the role of the amniotic membrane here is to act as a barrier to prevent the leakage of this fluid to the subretinal space. Now this diagram shows the pathogenesis of the neurosensorial detachment due to the presence of the optic disc pit. And this optic disc pit, they say either a liquefied vitreous or the CSF is leaking between the layers and the lamellae of the retina, leading to intraretinal schisis, and sometimes it will break through to the subretinal space. And that's why it is commonly associated with optic disc pit. There will be a macular serous detachment of the macula. So the role of amniotic membrane in this type of problems is act as a biological plug or biological scaffold that encourage the long-term closure of this hole so that prevent the communication between the subretinal space and the liquefied vitreous that lead to serous detachment of the macula. Now, if you see in this video, briefly, after doing pars plana vitrectomy, utilizing the triamcinolone to visualize the details of the vitreous, and after proper vitrectomy, the special type of amniotic membrane which is tailored to block that hole in the optic disc, and preferably should be a cryopreserved amniotic membrane, as you can see here, using a special forceps with a silicone tip so that it will plug the opening here on the optic disc in gentle way so that the minimum damage, and also this plug will prevent the fibrosis. So this is the plug, as you can see, after the operations. And after that you can see that this is the picture before doing the operations, how much is the retinoschisis is there, and after a while of using this plug, how the edema has been reduced and subsided. So this is one of the applications of the amniotic membrane in the presence of optic disc pit. Now, an important question is emerging after we knew the applications of the amniotic membrane, and one of the recent applications, apart from the external applications to the ocular surface, is the intraocular applications of the amniotic membrane, as I said earlier, in macular holes and optic disc pit. Now the question, what type of amniotic membrane is used intraocularly? Now, to answer this question, just follow the lecture and later on I will answer about this. This is very important because Due to the vast and the huge applications of the amniotic membranes, now there are different types like the dehydrated one, the decellularized one, and the cryopreserved, and the bioengineered, and the irradiated. There are plenty of types. So now you should know which one for which condition is used. The external use differs than the intraocular use. So the answer for this question, just follow this lecture and you will find the answer. Now we will speak about the most important type of amniotic membrane, which is known as the cryopreserved amniotic membrane, abbreviated as CAM. This is one of the most common and the most famous type of amniotic membrane that's used in ophthalmology, both for external use as well as intraocular use. In the next discussion, we'll speak a little bit more details about this type of amniotic membrane. Now, as far as the definition, the cryopreserved amniotic membrane is defined as it is amniotic membrane. It is the innermost layer of the placenta, harvested after cesarean section, and is preserved at ultra low temperature, very low temperature, reaching up to -80 centigrade. And the reason for that preservation, this preserves to large extent the biological activity of the membrane and maintain the structural integrity. These two variables are very important for any assessment of the amniotic membrane, is the biological activity as well as the structural integrity. The ideal amniotic membrane should contain as much as biologically active substances like growth factors, as well as should be structurally integral, so that can be easily handled during the surgical procedures. And the cryopreservation is made by keeping the membrane in the glycerol-based cryoprotectant, as I said, reaching up to a -80 degree Celsius. And this is the reason why a large extent or large amount of the growth factors and the extracellular matrix are preserved in this type of amniotic membrane. And the cryopreserved amniotic membrane is the gold standard in clinical use due to its balance of biological function, flexibility, and surgical handling, both for surgical for surface reconstruction and advanced posterior segment surgery. And this image show you the difference between the dehydrated amniotic membrane and the cryopreserved amniotic membrane. The cryopreserved maintains to a large extent the viable substances present in the amniotic membrane. However, the dehydrated one, it contains to a large extent the viable substance, but is not as much as the cryopreserved one. So in gross comparison between the dehydrated and the cryopreserved one, of course, both of them will undergo screening for pathogens, but the dehydrated one needs special no need for any special freezing process because it is dehydrated. However, the cryopreserved, we need this glycerol to maintain the -80 degrees Celsius for the preservation. And the dehydrated one is easy for transport. It is just placed in a nitrocellulose paper and easy for transportation. However, the cryopreserved, we should be careful because the accessibility for it, and first of all, it is expensive and it is not easy to get the cryopreserved one. Now the dehydrated one, it is very sticky. That's just you put it in the surface of the eye, it will stick immediately and you'll need not to add any sutures. However, the cryopreserved one, you need to have sutures. Now the other in this video animation, I will show how the cryopreserved amniotic membrane by Brochera rings is prepared. This was before they was preparing this manually. However, now it comes as a ready-made rings with the specific thickness, as I said before, according to the Brochera Slim or Brochera Classic. So you can see here that the amniotic membrane is customized to this ring, and it is very easily fitted with this ring with another ring placed on it, and the extra membrane will be brought to the center like this, so that it, as you can see here in this procedure, is placed over ocular surface, and this ring is kept or meant to separate the lids and prevent the symplepharon and adhesion between the lid and the conjunctiva. So this is demonstration how the Procera rings are prepared. I think that there are a vast varieties of application of the cryopreserved, but I will mention one of the most important effective use of the cryopreserved amniotic membrane that's used in severe to moderate to severe dry eye disease. And the reason for that, it is not just only give and provide immediate relief of the symptoms and dramatic reduction in the signs of the symptoms of dry eye, but also they found that it helped in the corneal nerve regenerations. And this is documented by in vivo confocal microscopy, so that they compare the patients who used this membrane before and after applications, and they found a tremendous increase in the density of the nerve fibers and the plexus and the improvement in the corneal sensitivity in these patients. So one of the major applications in dry eye. If you have a patient with dry eye, better to use the cryopreserved, not to use any other type of amniotic membrane. And as I said, the reason because it contains high amount of the biologically active ingredients and promotes epithelial cells healing as well as tear productions, and it has an anti-inflammatory role, especially the high molecular weight hyaluronic acid, Bintex 3. I will speak about it later. And it is very important to restore the homeostasis of the ocular surface. So in general, the cryopreserved one is very useful in the ocular surface diseases, either involving the cornea or the conjunctiva or the eyelid. And that's why it is the gold standard for most of the doctors to use the cryopreserved one, both for external use as well as for intraocular use. Now, as far as the different types of the commercially available amniotic membrane, just I will mention a few words with no any financial interest in these types. However, we should mention a few words about them so that the doctor will be aware about the type of amniotic membrane is using. Now, the most common one available in the market is the Procera, which is, as I said, this is a cryopreserved amniotic membrane. It comes with 3 or 4 varieties: the Procera Classic, Procera Slim, Procera, and Procera Plus. And this depends on based on the thickness. Each one has its own thickness according to the specifications here. And the more the severe the condition, the thicker the amniotic membrane that you need to use. For example, the Procera Classic comes with a very thick like this one, the thick orbital rim, so that it is act as a spacer, especially in symplepharons and prevention of closure or adhesions of the lids with the conjunctiva. And the Procera Slim is very mild to moderate indications such as the recurrent corneal erosions, because the thickness is around 100 microns. And the Procera more thicker, it is used in more severe conditions like neurotrophic keratitis, and Procera Plus in very severe form like in chemical injuries. Also, there is the Procera Clear, in which there is a central aperture so that it will not prevent the vision. So this is one of the most common types available in the market, which is a Procera, which is a cryopreserved amniotic membrane. Now, there are other types in the markets like the amniograft, which is also a cryopreserved one, and use it also for pterygium and ulcers. Also, you have the ambiodisc, which is a dehydrated amniotic membrane preserved by lyophilization. Use it also for corneal ulcers and dry eye. We have also the AmnioGuard, which is a cryopreserved amniotic membrane used for shunt and for glaucoma operations. And the graphics, this is not for ocular use. This is used in diabetic foods because amniotic membrane can be used for other applications for the skin treatment, which is also another cryopreserved amniotic membrane, but this is not for ocular applications. Still in the same context of the context dependent effect of the amniotic membrane. Now, for example, you are confronted with this scenario, and the examiner will ask you to match the following conditions so that you should understand the role of amniotic membrane in each condition. For example, in acute chemical burn. Now, what's the role of amniotic membrane in acute chemical burn? As we said that in acute chemical burn, the role of amniotic membrane is very important to reduce the acute severe inflammation and relieve the pain. However, when you look to the effect in or the role of amniotic membrane in persistent epithelial defect is to promote the epithelialization, and it acts as a scaffold for proliferation, migration, and differentiation of the cells. Now, the role of amniotic membrane in pterygium surgery is to reduce the recurrence and cover the pars sclera technique or the pars sclera area. Now, finally, in acute Stevens-Johnson syndrome or any acute inflammatory process in the surface of the eye, you can see that it is very important to prevent the symplepharon and reduce the acute inflammation. So this is the way how we understand the role of amniotic membrane in different situations. So it has a different role oriented to the underlying environment available in the eye. Now let's speak a few words about the different techniques of amniotic membrane applications. There are some famous way of applying the amniotic membrane on the eye done by many doctors. The most common is what's known as the inlay graft technique, in which the amniotic membrane is placed inside the defect of the cornea or the corneal ulcers, or the onlay patch technique or the overlay patch technique, in which the whole area of the eye is covered by the amniotic membrane, or the sandwich technique, which is a combination of both an inlay and overlay technique. Now we will discuss about each one separately. This is example of the inlay graft technique, and this is the overlay in which you apply the amniotic membrane over the whole surface of the eye. So we will speak about each one in details. The first common way of applying the amniotic membrane is known as the inlay graft technique, and this is usually kept for small epithelial defect or small corneal ulcers, so that the amniotic membrane is trimmed and placed in the defect and is secured by sutures or by using a fibrin glue. Now, the most important point is the orientation of the amniotic membrane here. In such cases, the basement membrane epithelial side should be facing up, so that it acts as a scaffold or bridge for the growth and migration and proliferation of the epithelial cells. This is very important, that we have to keep the epithelium and basement membrane side should be up, and the stromal side should be down. This is an example of the large epithelial defect, as you can see here, so that the amniotic membrane is placed inlay to cover the defect, and the edges are secured inside the defect and sutured by 10-0 nylon sutures, or you can use the fibrin glue. Note here that the cyanoacrylate glue is not advised in these cases, so you should use fibrin glue. This is another diagrammatic representation, so that the inlay graft is placed inside the defect. We don't cover the whole cornea. So the inlay patch act as a scaffold for the proliferation and healing of the epithelium, and we should keep the proper orientation of the amniotic membrane. The second way of applying the amniotic membrane is known as the overlay or patch technique, or onlay, also called as onlay. In this way, we are using the amniotic membrane not as a scaffold for the healing and proliferation of the epithelial cells, but we use it as a biological bandage. Instead of the contact lens or bandage contact lens, we use it as a biological bandage that we cover the whole surface of the eye and secure it by sutures, as you can see here, or also by the use of fibrin glue. And also the orientation here is very important. We have to keep the epithelial basement membrane side should be down, and the stromal side should be up in these cases. So it is indicated in the presence of generalized disease of the eye, like in acute burns, postoperative protections, or in preparation for the slit procedure in limbal stem cell deficiency. So this is the second type, which is known as the overlay or the patch technique. This is also the diagrammatic representation in which we apply the amniotic membrane over the whole surface of the eye. And as I said, we have to keep the orientation so that the stromal side or the epithelial basement membrane side should be facing down, and the stromal side, the sticky one, should be facing up. The third type of the application of the amniotic membrane is the use of the combined or sandwich technique, in which we combine both. We use the inlay patch to fulfill the gap or the corneal ulcer, and this acts as a scaffold for the healing and the proliferation of the epithelium, and cover it with an overall over the eye with an only graft with the amniotic membrane. So we utilize the advantage of both the structural support as well as the scaffold for the proliferation of the epithelium. And as you can see here in this video, after removing the epithelium, and we apply this inlay patch over the defective part of the cornea and secure the edges so that it is undermining the edge of the corneal epithelium, and also the orientation, as we said before, that the epithelial side should be up. And then we apply the overall onlay patch covering the whole part, and then secure it with sutures or with fibrin glue. So this is a sandwich technique. The other type is the multi-layer technique, in which we, when there is a deep defect in the cornea, so in these cases we use more than one layer of the amniotic membrane to cover the defect, as well as covered by another layer of external onlay graft. This is called multi-layer technique. As I said, also it will promote stromal regeneration and epithelialization over the cornea. So to sum up the different types of application, this is a comparative table showing the different types, the main types. That's the inlay, overlay patch, and the sandwich technique. The inlay graft act as a scaffold. The overlay patch act as a biological bandage for the cornea, and the sandwich technique is the combination of both. And the main purpose for the inlay to fill part the stroma, to act as a scaffold, as I said, and the overlay to promote the epithelial healing, and the sandwich will support both the structure as well as the healing of the epithelium. And the indications mainly for the inlay for the presence of focal defect, namely corneal ulcers or deep corneal ulcer or corneal melting. The overlay because it is dealing with the overall surface of the cornea, so it is suitable for persistent epithelial defects or neurotrophic keratitis or chemical injuries. And the sandwich technique when there is a corneal perforation, provided small size as explained before, or deep corneal ulcers, also in the presence of generalized corneal disease. And the orientation here, it is important, as we said, that the inlay patch, the epithelial side basement membrane should be up, and the stromal side should be down. The reverse for the overlay, and for the sandwich technique, you can use whatever as for the inlay and the overlay. And the fixation usually for the inlay, because of this is small, can be glued by the fibrin glue or by sutures, and the overlay can be must be sutured, and also you can use the glue. For the sandwich technique, you can use both, also the sutures and the glue, provided that you do them separately. And finally, as I said, there is a huge range of application for these types of grafts in persistent epithelial defects in dry eye, and also in ocular surface reconstructions. And this is the most common types of applications of amniotic membrane that is done by most of the doctors. Now we will speak about the different types of amniotic membrane forms available. Of course, the most primitive one is the fresh amniotic membrane, which is rarely used nowadays due to the high contamination risk and requires immediate tissue harvesting and processing. The most famous one is the cryopreserved amniotic membrane, and also the lyophilized amniotic membrane and the decellularized amniotic membrane. Then we have the irradiated amniotic membrane and finally the bioengineered amniotic membrane. We will speak a few words about each one of them, showing the pros and cons for each one of them. As you can see in this picture, this is an example or figure of a cryopreserved amniotic membrane. The patient is looked down and the membrane is slipped under the upper lid. When the patient looks straight ahead, the polymethyl acrylic ring will be centered by itself. This is used in treating especially dry eye patients. And this picture shows the appearance of the what's known as the decellularized amniotic membrane. That is, certain chemicals are applied to remove the cells, and there will be some advantage for this decellularized amniotic membrane. We will speak about it. One of the substances they use the trypsin enzyme so that they will digest the some of the cells, so that becomes more useful for clinical applications. This summary diagram shows the comparison between the different types of the amniotic membranes. As I said, the fresh one, which is rarely used nowadays because of the risk of the infection, the advantage that it doesn't need any storage and can be used immediately. However, it needs a thorough wash, and you need to make sure that there will be no transfer of infection from the donor to the recipient. It has the maximum biological activity but high risk of infection because all the mediators of the inflammations and the matrix and the biological substrates for the growth of the surface epithelium are there, but there is high risk of infections. The second most and the most commonly used one is the cryopreserved amniotic membrane, preserved under very low temperature reaching up to minus 80 centigrade, and is widely used in ophthalmology. And it has a high concentration of the preserved growth factors and extracellular matrix. And the disadvantage that it need a cold chain to preserve this membrane. And also they add some antibiotics to it to make sure that there is no risk of transfer of infections. The other type, which is the lyophilized amniotic membrane, which is also dry preservation using a freezing, but I will explain later the meaning of lyophilization. And the advantage that you don't need a very high, low temperature to preserve it, but you can use it with room temperature, and it is useful and convenient for use in general purposes in ophthalmology as well as in other specialties, and it has a long shelf life with substantial retained physiological factors and the growth factors that provide the effect of the amniotic membrane. The other famous one is also the decellularized amniotic membrane, which is enzymatically or physically they strip the cells from it so that it can be frozen and dried, and then by genetic engineering or tissue engineering, they can use it for limbal stem cell transplantations and so on. It has low immunogenicity and low risk of infections and is ideal for scaffold or what's called ex vivo cell transplantations. It is ideal for ex vivo cell transplantation, as we have explained in the lecture of limbal stem cell deficiency. The other one is the irradiated one, which is irradiated usually commonly by gamma irradiations or by what's known as E-beams. And the advantage, it make it suitable for storage at room temperature, and it has a reduction in the substance, the biologically active substance, but it can be used also for general purpose as well as in the eye as in the burns. The final one, which is the bioengineered amniotic membranes. And we will speak in details about this one because this is one of the most important preparations that is used for stem cell transplantations and the ex vivo expansion also, and tailored for specific healing effects and most commonly used in experimental purpose. Now we will speak about the meaning of decellularized amniotic membrane and the meaning of decellularization. It means that we apply physical or chemical or enzymatic substances to remove the cells while preserving the extracellular matrix. So our aim to preserve the extracellular matrix, and we remove the cells, as I said, either by physical, like freezing, and what's known as thaw cycle to lyse the cells, or by chemical detergents like the Tritan X100 or the Edita, or we use the enzymes like trypsin for removal of these cells. Then after applying this chemical substance or physical materials, it comes the stage of rinsing and sterilization through washing it with what's known as the PPS, which is stands for phosphate buffered saline. It is a special preparation of the normal saline, which is isotonic with special components. That's a water-based salt solution, which is commonly used in biological and medical laboratories. So after applying the physical or the chemical materials, we rinse and wash it with this PPS, and then we apply antibiotics followed by bacterial and viral deactivation via what's called as lyophilization and gamma irradiations, so that we secure the sterility of this membrane and removal of the cells and preserving the extracellular matrix. So decellularized amniotic membrane, it is acellular extracellular matrix. Then finally, after finishing all this process, it comes the process of final assessment using the evaluated by macroscopically whether the membrane is transparent and the texture, and then microscopically using hematoxylin eosin staining to ensure the cells are removed and only there is integral extracellular matrix is maintained. So this is, as I said before, this is a picture of the process of decellularization after applying the physical and chemical substances to remove the cells, and then the process of rinsing, sterilization, and finally by final assessment by electron microscope, or also by staining like hematoxylin eosin stain. Now this table shows the comparison between the natural amniotic membrane and the decellularized amniotic membrane. What's the advantage? As I said before, that's the natural amniotic membranes contains the maximum uh, biological factors that useful in the healing as well as maintaining the epithelium. But the decellularized will be less. But the natural one, as I said, rarely used because of the risk of the infections. The natural one contains all the components of the amniotic membrane. However, the decellularized one, it is only the extracellular matrix and there will be no cells. Now, as far as the immunogenicity, the amniotic membrane, as we said before, that has very low immunogenicity, but still some residual antigens are there. However, the decellularized one has very low immunogenicity. And as far as the biological activity, the maximum, of course, will be with the natural amniotic membrane. However, there will be some moderate reduction in the biologically active substance as it is still retained in the extracellular matrix. As far as the storage, the natural one is stored by cryopreservation or lyophilization. With it has a limited shelf life. However, the decellularized one has a better shelf life and can be sterilized and stored for long time. This is one advantage. As far as the structural integrity, more fragile. The natural one is more fragile, depends on the preparation. However, the decellularized one, it is more robust due to the extracellular matrix and the cross-linking. They after the removal of the cells, they do cross-linking, so it will be more stiff, a little bit more stiffer. So the handling will be better as compared to the natural one. As far as the scaffold for epithelial growth, it is the natural one is good for epithelial
support in the laboratory cultures as an ex vivo culture. However, the decellularized one has an excellent due to the preservation of the extracellular matrix and reduced inflammatory cells. So decellularized one is very useful in laboratory culture of the explants like in limbal stem cell transplants. Now, as far as the clinical safety, the natural one has proven safe, but some variability in the donor tissue. It depends on the donor tissue. However, the decellularized one, because of the absence of the cells, so it is potentially very safe and it has no risk of immunological reactions. Now, as far as the availability, the natural one is widely available. A commercial example is the Procera, which is shows the natural amniotic membrane. However, the decellularized one, because it needs special processing, so it is kept mainly for engineering, for tissue engineering, and it is a little bit expensive as compared to the natural one. Now, the common example for applications for the natural one is in acute ulcers, burns, stem cell support. However, the decellularized one for corneal regenerations, limbal stem cell deficiency culture, and also as a drug delivery. So this is broadly the difference between the natural amniotic membrane and the decellularized amniotic membrane. Now we come to the other type of the amniotic membranes, which is known as the lyophilized amniotic membrane. We should understand the meaning of lyophilization. It is a two-process procedure by which we preserve the amniotic membrane, done by freezing first, so that it is frozen at a particular temperature. Then the frozen water content of the tissue is allowed under low pressure to be evaporated without passing through the water condition. So 95% of the water will be lost from the tissue and evaporized. Then another drying is done by removing the residual amount of water which is present, so that we reach to the very proper drying of the tissue and get preserved with extension of the shelf life without the need for a very low temperature like in a cryopreservation. So lyophilization, which is freezing and drying, is a preservation technique used to remove the water from the biological material by freezing first and then reducing the surrounding pressure to allow the frozen water to what's known as sublimate. Sublimate means it is directly turning to a gas without becoming a liquid. The advantage of this technique of lyophilization in the medical applications that it provides a longer shelf life for the amniotic membranes, and then no need for refrigeration under very low temperatures and as in cryopreservations. Also preserves the structural integrity of the tissue, like the collagen and the network of the in amniotic membrane, and reduces the microbial growth because there's no water, so there will be no microbial activity, and easier transportation and storage. And the application for this lyophilization amniotic membrane, it is used adjuvant or in adjunct with decellularized amniotic membranes. So we can apply the same principle to a decellularized membrane. And it is also useful to stabilize the extracellular matrix and preserve the membrane for clinical use, especially during the tissue engineering. So it provides a sterile packing under a local temperature, no need for cryopreservation. Now we come to the recent variety of amniotic membrane, which is bioengineered one, which is named as bioengineered amniotic membrane scaffold. It is one of the most promising tools in especially in limbal stem cell deficiency, as we have explained in that lecture. They combine the natural benefits of amniotic membrane with the advanced engineering for better support of the limbal stem cell expansions and ex vivo expansions and the survival of these cells. So this bioengineered amniotic membrane scaffold is nothing just an amniotic membrane that has been modified or enhanced in its structure and composition to function and to serve to provide an optimum substrate for cell growth. So especially in limbal epithelial stem cell disease. So the term HAMTW, which likely refers to the human amniotic membrane treated with trypsin and washing. So as you know, when we spoke in the lecture of limbal stem cell deficiency, that when we do ex vivo expansion of the limbal stem cells, we need to provide a very proper environment for the cells to grow and multiply. And one of these processes is by providing the amniotic membrane to be as a substrate for the growth of these cells. Now it is not just enough the amniotic membrane, but it is genetically modified so that it provides the optimum substrate for the cell growth. And one of this optimization is by adding trypsin and some washing materials to make it proper media for the growth of the limbal stem cells. So the modification that they apply to the amniotic membranes include different steps of decellularization first, followed by cross-linking of the layers of the amniotic membrane, and then seeding with limbal stem cells to induce pluripotent stem cells, then the integration with nanofibers or hydrogel bioactive molecules, and embedding also some drugs to maintain the sterility as well as reduce the inflammation. All these processes are done to the amniotic membrane so that it provides the optimum environment for the growth of the stem cells. This is known as bioengineered amniotic membrane scaffold. Now in this table, I will show some of the advantages over the traditional amniotic membrane, as you can see here. The features of the conventional amniotic membrane and the feature of the bioengineered amniotic membrane, both as far as the limbal stem cell support, both they will support the limbal stem cells, but the bioengineered one has a maximum capability for supporting the growth of the limbal stem cells. As far as the mechanical strength, the natural one has very low support as compared to the bioengineered one, which undergoes cross-linking. So it is suitable for handling. This one is more suitable for handling than the conventional one. Now, as far as the risk of immune rejection, as you know, amniotic membrane has very low risk of rejection, amniotic membrane. However, the bioengineered one, because of the decellularization that we have explained before, it has very minimum risk of rejection. As far as the storage, the bioengineered one has optimum storage at a temperature room or room temperature because of the lyophilization that we have explained before. However, this one should be applied immediately, or you have to do a cryopreservations. And as far as the addition of drugs, we can add some drugs to the bioengineered amniotic membrane, either to reduce the inflammation as anti-inflammatory or to maintain the sterility. So these are the major advantages and disadvantages of the conventional amniotic membrane as compared to the bioengineered amniotic membrane. Now in this table, I will show a comparison between one of the common bioengineered human amniotic membrane, which is known as a human amniotic membrane scaffold, and another variety, which is the HAMTW, which is also another variety, but it is mainly a decellularized membrane. Now, the human amniotic membrane scaffold is a final membrane that's used for growth of the cell cultures and the limbal stem cells. It is defined as a scaffold for human amniotic membrane, processed for use for biology as a biological matrix. So this is the matrix or the culture media that's used for the growth of the stem cells. However, this membrane is treated with trypsin enzyme and is then washed. So the aim is just to decellularize the membrane, but still it is not as biological matrix preparation as this one. Okay. Now the purpose of this one membrane is used as I said, to be a biocompatible scaffold for cell seeding and cell transplantation. However, this one is primarily used to decellularize the amniotic membrane while processing and preserving the extracellular matrix. Both of them are used for cell seeding. However, this one is optimum and much more ideal. The processing method include decellularization, sterilization, and then cross-linking, and finally preservation by lyophilization, as I explained before, or by cryopreservation. However, this one, it contains trypsin application and removal of the epithelial cells, followed by PPS application and washing. So there is no cross-linking in this type or this variety of human amniotic membrane. Now, as far as the decellularization status, both of them, they will have decellularization. However, this one full decellularization and this one partial decellularization. As long as the decellularization is maximum here, so this secure that there is no immunogenicity. However, this is a partial decellularization. As far as immunogenicity, as I said, there will be very low immunogenicity in this one and moderate in this one. And the structural integrity, as I said, because of the cross-linking, so this is a reinforced the human amniotic membrane. However, this one, as compared, is less stiff than this one. Application mainly in limbal stem cell therapy, or also skin and wound growth, wound grafts. However, this one is used as a substrate for in vitro limbal stem cell expansions and ophthalmic graft with reduced immunogenicity. So this is mainly used as in vitro or in laboratory cultures. This one also is used, but this one is more ideal. In the literature, this is a tissue engineered carrier for the cells. However, this one is a precursor step to prepare for decellularization of the amniotic membrane. Now, the storage, often lyophilization and cryopreservation can be done in this one, and this one can be applied or used as a fresh or by cryopreservation for short time. Now, as you can understand from this, that this carries a high complex processing and would be more expensive than as compared to this one. Just I like it to give a differentiation between these two types of examples of bioengineered human amniotic membranes, just in case anyone asks you, do you know any example of bioengineered amniotic membrane, and which one is the ideal for cell seeding and ex vivo expansions, will be the HAMS, which is the human amniotic membrane scaffold. So in summary, the human amniotic membrane TW is typically used as a preliminary for as a decellularization step, so that preparing the amniotic membrane for cell culture and scaffold application. However, this one is a final product. The HAMS is a final product which is already undergo decellularization along with cross-linking. Now let's come to the answer for this question that we have asked before about the type of amniotic membrane which is ideal for intraocular use. The answer for this question is the use of cryopreserved amniotic membrane is ideal and preferred because of its structural integrity, and it is full of biologically active substances and its biocompatibility and bioactivity. It is full of bioactive substances. However, the dehydrated and the bioengineered ones are not suitable because they are the bioengineered still used for mainly for experimental use, like in the limbal stem cells, and the dehydrated one is fragile and cannot be used for intraocular use. One important emerging question for the postgraduate student, that's why procedures that is preserving and respecting the Bowman's layer, like LASIK procedure, it has less fibrosis induction rate as compared to those who disrupt and don't respect the Bowman's membrane, like the PRK. And what's the role of the amniotic membrane in controlling such disruption for the Bowman's membrane, and what's known as Bowman's-like effect of the amniotic membrane? Now, to answer this question, we have to speak some few words about the reason why the Bowman's membrane disruption will lead to induction of haze and fibrosis in the underlying stroma. Now, the function of the Bowman's membrane, it's a very important physical barrier that separates between the epithelium and the stroma, and act as a molecular filter that restricts the diffusion of the cytokines and the mediators of the inflammation from the surface of the cornea towards the stroma. So this stabilizes and maintains the stromal keratocytes quietness, and there will be no any stimulation for the keratocytes or fibroblast formation. Now, disruption of this membrane, that's the Bowman's membrane, will result in direct contact between the epithelium and the stromal cells, and also there will be diffusion of the cytokines and mediators to the inflammation inside the stroma, and this will lead to the activation of the latent transforming growth factor beta, which is stored in the stroma. Now, the role of amniotic membrane in this type of inflammation, that it acts as a like a Bowman's membrane-like effect. So they found that by early application of the amniotic membrane to these cases, it will minimize the haziness that's seen and the fibrosis that's seen in the stroma after disruption of the Bowman's membrane. That's why it is advisable to immediately use the amniotic membrane in which there is acute disruption of the Bowman's layer. So it is very important that whenever you want to do any procedure to the cornea, avoid disruption of the Bowman's membrane. That's why always we see post-operative haze after PRK, which is not seen in post-LASIK cases. Now we reach to the final sum up and the conclusion. And before we finish this lecture, I just like to add a few words about the future prospect of this newly emerging modality of therapy for ocular surface and ocular surface problems and ocular surface reconstructions. There are a lot of emerging or future prospects for this new applications of the amniotic membranes, and still experiments are going on in the bioengineered amniotic membrane. That's they add a lot of substances to the amniotic membrane by genetic engineering, so that it enrich this membrane with useful substances that promotes the healing process as well as prevent the fibrosis. Also, there is a novel delivery techniques, especially what's known as the amniotic membrane extracts. We'll speak about it, and a huge combination and synergy between the use of amniotic membrane as a scaffold for the limbal stem cell therapy. We will speak a few words about this future prospects of the amniotic membrane. Now, after most of the doctors, they realize the importance of the amniotic membrane as a strong, powerful regenerative tool in ocular surface problems and ocular reconstructions. A novel idea came up that why not to use the amniotic membrane extract in the treatment rather than using the amniotic membrane itself. The idea is that we utilize all the biologically active components of the amniotic membrane, like the anti-scarring proteins, anti-angiogenic and anti-inflammatory proteins, and all the components of the extracellular matrix, like the laminin and fibronectins. And then they gets frozen and by special lyophilization and preparing special preparation that can be used as an eye drops. Now, the preparation for this amniotic membrane extract is simple as that. After selecting the amniotic membrane from the donor and screening after the selective and elective cesarean section has been done, this membrane undergoes some sort of mechanical homogenization and enzymatic digestion and filtration, so that the extract is stored as an eye drops with a short shelf life, or a little bit as a longer shelf life as a lyophilized powder. Now, the advantage of this amniotic membrane extract as compared to the intact amniotic membrane, that it can be used as an outpatient treatment, repeatable, and there is no any need for any surgical interventions, and you can use it as drops or as powder. Now, this is one of the recent innovations in the field of amniotic membrane as a regenerative therapy, is to use it as amniotic membrane extract. The second important future prospect of the amniotic membrane applications is the use in conjunction and as a synergistic role with the limbal stem cell deficiency. As we have mentioned in the lecture of limbal stem cell deficiency, that amniotic membrane has an integral part of the success of many types of the procedures of limbal stem cell deficiency. Namely the slit and the clit, and also some of the conjunctival limbal autologous grafts, We have explained this in the lecture of the limbal stem cell therapy. The main role of amniotic membrane in limbal stem cell therapy, or in conjunction with limbal stem cell therapy, mainly two rules. It acts as a substrate for the stem cell expansion ex vivo, that's in external media, like in a clit procedure, that's conjunctival limbal epithelial transplantations. So it acts as a substrate for ex vivo expansion. At the same time, it is important as a biological dressing or enhancing the healing and protect the graft after doing the transplantation, like in slit procedures. So the major role of the amniotic membrane as a substrate or a scaffold for ex vivo expansion, especially the clit procedures, or as a protection for the or biological bandage for the limbal stem cells after being implanted, like in the slit procedure, as it is promoting the healing and decrease the angiogenesis and decrease the fibrosis and enhance the differentiation of this epithelial cells. So if we look to this table, this is just a comparison of the role of the amniotic membrane in the stem cell therapy in a clit procedure, which acts as a scaffold for ex vivo expansion, and in a slit procedure use it as a biological bandage for the limbal stem cells. Also in the CLAW procedure and LST procedures, that's the limbal stem cell therapy, allogenic grafts. So this is the main role of amniotic membrane in conjunction with limbal stem cell deficiency. By this level, we reach to the end of this lecture, and these are some of the references that helps me to prepare this lecture. At the end, I hope that I have made an impression for you about the significance of amniotic membrane. It is not just a thin, fragile, simple membrane that protects the baby during the intrauterine life, but the wisdom of our Creator that this thin membrane is also useful in providing the vision for the people after birth. And as our God said in the Quran, وَفِي أَنفُسِكُمْ أَفَلَا تَعْلَمُونَ. So this amniotic membrane opened the door for the new scientific prospect of the regenerative therapy. So instead of dealing with the damaged tissue, we can heal these tissues from our own body. So the principles of regenerative therapy, in which the amniotic membrane is one of the strong bases of this new science that is emerging nowadays. So I hope that you have enjoyed and benefited from this lecture, and I'm looking forward to meet you soon in another session, in another lecture among the series of Ophthalmology Made Easy, that is problem-solving questions for the FRCS students. I have made a revision for all of the lectures that I have made in the cornea in the form of problem-solving oriented questions toward the FRCS and the Libyan board to help the candidates appearing in these exams. Looking forward to meet you soon. I hope that you will be safe and wish you the best of luck.